everybody, according where are you in the world. It's my great pleasure to introduce Dr. Müller. Dr. Müller did his residency in radiology at the University of British Columbia, followed by a fellowship in University of California, San Francisco, before joining radiology staff at Vancouver General Hospital and the University of British Columbia. He was the head and medical director of the Department of Radiology at Vancouver General Hospital and chairman of the Department of Radiology at the University of British Columbia from 2000 until 2010. He was also the president of the Society of Thoracic Radiology. Dr. Müller has authored and co-authored more than 450 publications and more than 17 books. He has won a number of awards, including recognition by the editor of the American Journal of Rheumatology and being one of the 3 wise men in radiology as an outstanding teacher and scholar. He also won the gold medal of the Brazilian College of Radiology and the gold medal of the Society of Thoracic Radiology. Thank you, Doctor, for giving us some time and for approving to give this lecture. Thank you so much.
Thank you, Dr. Badawi, for your kind introduction. It's a great pleasure to participate in this series of lectures by the Health for the World organization. Good morning, afternoon, or evening to everybody, depending on where you are. Having reviewed thousands of chest radiographs of patients with tuberculosis in my life and hundreds of CT scans, I thought this was a good opportunity to summarize some of my findings, particularly since TB continues to be a major problem throughout the world, particularly in Africa. Well, let me just go to my lecture. And I have to share the screen. So to do that, share the screen. I trust that everybody can see the screen now. Yes? Okay. So my lecture is on pulmonary tuberculosis. I have no conflict of interest. And what I want to do in the next 40 minutes or so is to review the radiographic and CT manifestations of TB in adults, including HIV negative and HIV positive patients, illustrate the typical findings as well as less common presentations. TB is one of the top 10 causes of death worldwide. In 2019, an estimated 10 million people fell ill with TB, and an estimated 1.4 million died from TB, 25% of these in Africa. If we look at the prevalence of tuberculosis throughout the world, we can see that the vast majority of cases occur in Africa and in Asia. And thus, there's the importance of this topic for Africa. The risk factors for TB include exposure, particularly in Africa and Asia, young age, malnutrition, intravenous drug abuse, and immunodeficiency, particularly HIV. Overall, men account for 56% of cases, women 32%, and children 12%. 8% are HIV positive, and most of these live in Africa. TB occurs within the first year after exposure. After the patient is exposed to TB, in 95% of cases, host immunity limits the multiplication of the bacteria. The patient remains asymptomatic and the lesions heal by themselves. In some cases, this primary infection may heal with calcification of the primary infection and or regional lymph nodes. But it's important to realize that even though these lesions heal, even if they are calcified, organisms may be live within them, but dormant, and this is called latent infection. And these then later in life may reactivate. So in some patients, we can see these healed foci in the lung in adults as calcified granulomas. This is also called the gone focus. The combination of the calcified granuloma and the calcified hilar or mediastinal lymph node is also called the Ranke complex. It just tells us that this patient has been exposed to TB and he has a healed lesion. Of course, we can see the same findings on the chest radiograph, a healed calcified granuloma, and in this case, calcified paratracheal lymph nodes. In about 5% of infected individuals, when they get infected, the immunity is inadequate and they develop active disease, usually within the first year of exposure. This is primary TB. The patients who tend to develop this are primarily children under the age of 5 and HIV-infected individuals. In another 5%, endogenous reactivation of the latent infection occurs many years after the initial infection. But it's important to realize that post-primary TB may occur not only by a reactivation of the latent focus, but also by reinfection. In a high prevalence setting, particularly Africa, reinfection may occur in up to 50% of cases, but particularly HIV positive patients, compared to less than 10% in HIV negative patients. Thus, when we see a patient who has findings of TB, we should think in terms of primary and post-primary rather than reactivation, because they may not have reactivation of disease, but rather reinfection. Now, the radiologic manifestations in patients who have normal immune function can be categorized into two types, primary and post-primary. In primary TB, particularly in children, the hallmark is lymphadenopathy. This is usually hilar and right paratracheal. On CT, what we do see in the enlarged nodes that they typically are necrotic, leading to low attenuation centers and peripheral enhancement on the CT. So this is a young adult patient with primary TB. What we see here is marked left hilar lymphadenopathy, which was the only manifestation in this patient. In another patient, what we see is extensive paratracheal lymphadenopathy as the only manifestation. The CT scan in this patient showed the enlarged paratracheal lymph nodes with low attenuation center consistent with necrosis. Very typical in tuberculosis. As I mentioned, the lymphadenopathy is mainly hilar and paratracheal. But it's important to realize that the prevalence decreases with age. While the vast majority of children with primary TB have lymphadenopathy, only 40% of adults under 35 have lymphadenopathy, and only 10% of patients with over 50 with primary TB have lymphadenopathy. On the other hand, consolidation tends to be more common in adults. The consolidation in primary TB can affect any lobe, although tends to be most common in the lower lobes, and it tends to be homogeneous. So this is an adult patient with primary tuberculosis. What we see here is dense consolidation in the right middle lobe. You can also see that the major fissure is displaced anteriorly, telling us that this patient has some volume loss due to obstructive pneumonitis. We also see enlargement of the right hilar lymph nodes. CT scan in this patient shows enlarged right hilar and subcarinal lymph nodes, again with the typical low attenuation centers and rim enhancement due to necrosis. Patient also has a small pleural diffusion. On the CT, we again see the dense consolidation throughout the right middle lobe. It's homogeneous, in this case without air bronchograms due to obstructive pneumonitis by the enlarged hilar lymph nodes. As I said, the consolidation tends to be homogeneous, involves any lobe, most common in the lower lobes, in this case middle lobe, but sometimes it can be quite extensive. This patient presented with extensive bilateral consolidation and was thought to have a regular pneumonia, but it turned out to be tuberculous pneumonia. Now, the most common presentation in adults is that of post-primary TB. In these patients, the vast majority have consolidation, and this tends to be heterogeneous with very poorly defined margins on the chest radiograph. And it is often associated with small nodular and linear opacities. The consolidation typically involves the apical and posterior segments of the upper lobes, in the vast majority of cases, 85%, or the superior segments of the lower lobes, 10%, often with cavitation, which we see in about 45% of chest radiographs. Another important presentation seen in 5% of cases is that of a well-defined round lesion ranging from 0.5 centimeter to 4 centimeters in diameter, which is the tuberculoma, which often mimics carcinoma. So there's an adult patient with post-primary TB, young adult, 19-year-old. And what we see on the chest radiograph is this small area of consolidation in the right upper lobe, poorly defined margins. And when we magnify this, it's better to see it. Again, this poorly defined consolidation, a bit nodular appearance, as well as other small nodular areas of opacities. These findings in this location, upper lobe, poorly defined consolidation, small nodules, are highly suggestive of TB. CT scan in this patient, again, shows the small area of consolidation, and it shows these small nodules, which are centrilobular in distribution, typical of tuberculosis. This patient did not have any cavitation. In another patient, another young adult, what we see here is more extensive upper lobe consolidation, again with poorly defined margins. And we can see a small right upper lobe cavity. Such an appearance is virtually diagnostic of tuberculosis. The CT scan shows essentially the same things. We see this cavity, and we see another smaller cavity that in retrospect is visible on the radiograph. We can also see that this patient has involvement in the lower lobes due to endobronchial spread of tuberculosis from the upper to the lower lobes. In another patient, fairly similar findings. What we see here, when you right upper lobe again, are poorly defined, small area of consolidation, and these nodular opacities. On the CT, the consolidation, and these nodular opacities, which has a little bit of a branching configuration between name, tree, and bud appearance. Again, quite typical of post-primary tuberculosis. But in some cases, the disease involves mainly the lower lobes. Here we have a patient, another young adult, that has this cavity in the superior segment. As I mentioned before, in 15% of cases, the infection involves mainly the superior segment of the lower lobes. This cavity, and then these nodules in the right middle lobe due to endobronchial spread from the disease that started in the left lower lobe, in the right lower lobe. Another patient, in this case with bilateral upper lobe abnormalities, poorly defined nodular opacities, some small, poorly defined areas of consolidation, some small nodules, some linear opacities. And again, on the CT, we see similar findings, nodular opacities, a cavity, and centrilobular opacities with a tree and bud pattern. So this patient has cavitary TB with endobronchial spread of disease. Now notice again that although on the radiograph, the findings seem to be mainly in the upper lobes, there's quite a bit of disease in the superior segments of the lower lobes, and that is where the cavity is. This patient with much more extensive disease, very severe bilateral upper lobe areas of consolidation, and multiple cavities in the upper lobes and the superior segment of the left lower lobe, and poorly defined nodular opacities. Cavitation is seen on the radiograph in about 45% of cases, and on CT we see it in about 80 to 90% of cases. Endobronchial spread is seen in about 20% of cases on the radiograph, but on the CT we see that the patients have endobronchial spread in 95% of cases, much more common than we see on the radiograph. And it may be to the same lobe or to multiple other lobes. This endobronchial spread is characterized on CT by the presence of centrilobular nodules, typically with a tree and bud pattern. They typically measure between 5 and 10 millimeters in diameter. They are centrilobular because the spread occurs via the airways, and what we see there on these findings are the involvement of the bronchioles, the small airways, leading to the centrilobular distribution and tree and bud pattern. Here's a patient that didn't have consolidation, didn't have cavitation, only had these centrilobular nodules. We know that they are centrilobular because they are a few millimeters away from the pleura and the interlobular septa and interlobar fissures. So they are centrilobular. Now, if we do a maximum intensity projection image, MIP image, we can see that there are actually branching opacities due to this spread via the small airways, the bronchioles. Tree and bud pattern, a very characteristic feature of TB, but also seen in any infectious bronchiolitis of any cause. So in this case, we have a 27-year-old who presented with extensive right upper lobe consolidation and multiple nodules in the right lower lung and in the left lower lobe due to endobronchial spread of tuberculosis. In this patient, right upper lobe, nodularity, consolidation, cavitation, with endobronchial spread to the contralateral lung and some spread into the right lower lung. The CT scan shows a cavity in the superior segment of the right lower lobe and extensive centrilobular nodularity bilaterally due to endobronchial spread of TB. Features like this are, again, virtually diagnostic of tuberculosis. This chest radiograph is more difficult because what we see are multiple large nodules as well as small nodules throughout both lungs. And in such case, on the radiograph, there is really a broad differential diagnosis. CT scan in this patient makes life much easier for the radiologist, showing multiple cavities and multiple centrilobular nodules with a tree and bud pattern, again, virtually diagnostic of tuberculosis. In this patient, you see nodules only in the lower lung zone. And again, there's a broad differential diagnosis, but this turned out to be tuberculosis with endobronchial spread. The CT scan shows bilateral centrilobular nodules, and it shows this cavity in the left lower lobe from where the spread originated. In this patient, similar findings except in the contralateral lung. Tree and bud pattern involving mainly the right lower lobe. This patient did not have any visible cavity on the CT scan. All we saw were these centrilobular nodules and tree and bud pattern that led to the high suspicion for tuberculosis, which was then confirmed. As I mentioned before, in about 5% of cases, TB manifests as a single nodule measuring anywhere from 0.5 to 4 cm in diameter, which is called a tuberculoma. In this patient, we have this large nodule in the right lung, which is better seen on the CT scan, and it turned out to be a tuberculoma. This patient did not have any symptoms. This was an incidental finding on the chest radiograph. This patient had an initial CT for suspected interstitial lung disease, which this patient did not have, but this patient did have a left apical nodule. Follow-up CT 3 months later, which is what you are seeing, showed that the nodule had increased slightly, had irregular margins, and all cultures had been negative. The patient went to surgery, and it turned out to be a tuberculoma. In retrospect, this surgery could have been avoided if a biopsy had been done. Just points out that we have difficulty from the CT and radiograph in distinguishing tuberculomas from cancer. And in high endemic regions, of course, we have to keep in mind the possibility of tuberculosis. Clinical significant miliary disease occurs in 1 to 7% of patients with all forms of tuberculosis. It is caused by hematogenous spread. It can affect many organs, liver, spleen, etc. It is usually seen in infants, elderly, and immunocompromised patients, particularly patients with AIDS. What we see are small nodules, 1 to 3 millimeter diameter, randomly distributed throughout the lungs. It is important to realize that these patients may present with fever, but the initial radiograph may be normal. In a study that we did many years ago, we found that the initial radiograph at presentation was normal in 65% of cases. And the miliary nodules could only be seen 2, 3, 4, 5 days after the initial presentation. Here's a patient with miliary tuberculosis. What we see are a myriad of very tiny nodules throughout both lungs. Better to be seen in this magnified image of the lung. And of course, much easier to visualize on the CT scan. These numerous nodules throughout both lungs, typical of miliary TB. Another patient showing again innumerable nodules really throughout the lungs on the chest radiograph and CT, patient with miliary TB. Now, in some cases, the findings are a little bit more subtle when you look at this radiograph. And particularly if you don't do it carefully, you may miss these very tiny nodules and only see this haze increased opacity. But again, on the CT, it's easy to identify them as numerous nodules in a patient with miliary TB. We can see other manifestations on the chest radiograph and CT, including airway involvement, pleural diffusion, empyema, and spondylitis. Bronchial narrowing or complete obstruction may occur due to compression by the enlarged lymph nodes, due to bronchial wall thickening by direct bronchial involvement in active TB, or due to extensive TB scarring. It may result in distal atelectasis or obstructive pneumonitis. Here is an example of a patient with active TB with associated narrowing of the main bronchus due to marked bronchial wall thickening due to TB. It can involve the main bronchi, but more commonly we see the involvement in the lobar bronchi. In this patient with tuberculosis, we see thickening of the posterior wall of the main and upper lobe bronchus and marked thickening and narrowing of the bronchus intermedius, which was proven to be due to active tuberculosis. Here is a patient that was admitted on September 8 last year with extensive left upper lobe disease, nodules, consolidation. A few weeks later, the X-ray had changed, but it really didn't, the patient really didn't have much improvement. And then a few weeks, a month or so later, the patient presented with this dense opacity in the left upper lobe. And when we look carefully, we can see that there is forward displacement of the major fissure, indicating the patient had left upper lobe atelectasis. And the patient also had a small left apical pneumothorax. CT scan in this 20-year-old patient demonstrated at presentation that the left bronchus was normal and the left upper lobe bronchus was patent. However, on the follow-up in December, you can see marked narrowing of the left bronchus and complete obstruction of the left upper lobe bronchus, atelectasis of the left upper lobe, and pneumothorax. Again, another example of marked bronchial narrowing and obstruction due to active tuberculosis. This patient illustrates another complication that we may see, which is not really severe, but can be seen in TB. And this patient obviously presented with severe tuberculosis, upper lobe cavities, numerous nodules, areas of consolidation, extensive endobronchial spread. And on the follow-up of this patient, what we saw was improvement of the tuberculosis, but development of pneumatocele. These are not cavities, these are pneumatocele. These are very thin, smoothly marginated walls. This is a well-known, but not very common complications of tuberculosis. Now, some of these pneumatoceles may lead to pneumothorax. That gives them some importance in clinical practice. Pleural diffusion is relatively common in about 15 to 25% of patients with TB, but it's usually very small, and it's usually due to a hypersensitivity reaction, not pleural infection, so it doesn't lead to any complication. However, in a small percentage of cases, diffusions may actually represent a tuberculous empyema, which often is larger and is often loculated, and on the CT scan associated with pleural thickening and enhancement. There's a patient, again, young adult male with tuberculosis, showing a large loculated right pleural diffusion. And you can see the pleural thickening and enhancement on the CT due to a large tuberculous empyema. In another patient who presented with a hydropneumothorax, we can see the thick rim of the pleura, even on the visceral pleural, even on the chest radiograph. We have the hydropneumothorax, and we have the patient has a cavity visible on the radiograph, which on the CT scan, we can see the direct communication of the cavity with the adenopathy, actually a tuberculous empyema due to TB. So bronchopleural fistula related to tuberculosis. Another complication that we can identify on the radiograph and CT is tuberculosis spondylitis, which occurs in 1 to 5% of patients with TB. In our experience, it's more 1%, but in other areas, it can occur in up to 5% of patients. Typically involves the thoracic spine, leads to destruction of the anterior portion of the end plate, leading to focal kyphosis, intraosseous and paravertebral abscesses. It is important to keep tuberculosis spondylitis in mind when we evaluate patients with suspected TB, because the findings may be quite subtle. So it's important to pay attention on the details on the radiograph. In this patient, we can see some small nodules, small poorly defined areas of consolidation in the left upper lobe, fairly typical of TB. And if we look carefully at the radiograph, we can see obvious displacement of the paraspinal interfaces, highly suggestive of tuberculosis spondylitis in this clinical context. CT shows extensive paraspinal abscesses and marked destruction of the vertebral bodies due to tuberculosis. Unfortunately, we see this in the 21st century, even in Canada, and we see it quite often in other countries. Now, tuberculosis and HIV is a problem that occurs particularly in Africa, which has 75% of the cases of HIV-associated TB. The risk of developing TB is 20 times greater in HIV positive than in HIV negative persons, and the mortality is substantially higher. TB, particularly in Africa, is the leading cause of death, hospitalization, and in-hospital death in patients with HIV. So it is really a huge problem in many countries in Africa. The radiologic manifestations of TB and HIV are variable depending on the degree of immunity of these patients. In patients who have slightly decreased immunity, namely over 200 cells, the findings are those of postprimary TB. But if the immunity is more severely involved, they have findings that are more similar to primary TB, or they develop miliary TB. And if the immunity is severe, the findings are totally non-specific, and the radiograph may even be normal in patients with disseminated tuberculosis. So there's a patient that has a mild decrease in immunity, and the findings are those of postprimary TB in the patient with HIV. Upper lobe cavities, poorly defined consolidation, multiple nodules. Another patient, again, mild decrease immunity, findings resemble those of postprimary TB. Here's a patient with, again, mild decrease immunity, typical findings of postprimary TB with cavitation, central lobular nodules, etc. However, when the immunity is more severely compromised, namely less than 200 cells, CD4 cells, they present with findings more typical of primary TB, namely with mainly lymphadenopathy, again with the typical low attenuation centers due to necrosis. Or they may present with miliary tuberculosis. Now, it's important to realize that patients who have HIV and develop tuberculosis, if they are treated at that time, they can develop what is called immune reconstitution inflammatory syndrome, IRIS, which leads to a paradoxical worsening of the pulmonary disease following treatment for HIV and treatment with TB. They get worsening of lymphadenopathy and worsening of the consolidation and nodules. This occurs in about 10 to 25% of patients with AIDS. Here is an example of a patient that was HIV positive, severely immunocompromised, and presented with these numerous nodules in the upper, predominantly in the upper lobes, and a slightly enlarged paratracheal lymph node. This patient was started on antituberculous treatment and antiviral treatment. Following, and 2 weeks later, this is what we saw. Marked increase in the parenchymal abnormalities, numerous new nodules, new areas of consolidation, and dramatic increase in the lymphadenopathy, these large necrotic lymph nodes. Even though this patient was started to respond to his HIV treatment, his TB seemed to get much worse. He was then started also on corticosteroids and rapidly improved over the following few weeks. So be aware that even though the patient may look much worse because of this inflammatory response. In practice, they are actually responding to the HIV treatment, although the TB certainly looks worse. Here is the comparison of the radiograph and CTs at presentation and on follow-up, just to emphasize the dramatic worsening due to immune reconstitution syndrome. So in summary, findings of active tuberculosis include cavitation, consolidation, centrilobular nodules in tree and bud pattern, miliary nodules, lymphadenopathy, and pleural effusion. None of these findings is diagnostic. However, if we see cavitation and consolidation poorly defined in the upper lobes, particularly apical and posterior segments, or superior segments and the lower lobes, with centrilobular nodules, the diagnosis is almost certainly tuberculosis. And if we see any of these findings, we have to keep in mind the diagnosis of TB. Findings of inactive TB, previous TB, are calcified nodules, calcified hilar or mediastinal nodes, upper lobe scarring and volume nodes, peribronchial scarring, and fibronodular scarring. But it's important to realize that when we see fibronodular upper lobe opacities, we have to think of TB, and it may be active or not active. And when we see a fair bit of scarring, this has to be stable for at least 6 months for us to consider this to be inactive TB. Until proven otherwise, these patients have to be evaluated for possible active disease. The radiograph, of course, is important in the evaluation and risk stratification of patients with suspected of having latent or inactive TB and in identifying active disease. The radiology report should describe whether the radiograph is normal, shows calcified granulomas, fibronodular scarring, noting the duration of stability, or findings suspicious for active tuberculosis. The X-ray has a high sensitivity for TB, but we have to be aware that even though some of the abnormalities may be highly specific, like the ones I mentioned, particularly cavities, the overall specificity is low because many of the abnormalities consistent with TB are also seen in several other diseases. But when we see any of the findings that I've shown and summarized, we should think of the possibility of tuberculosis so that an early diagnosis is made. Now, I illustrated a lot of CT scans to illustrate the typical findings on the radiograph and the CT. But in practice, we do CT in a small percentage of patients with tuberculosis. It, of course, has a high sensitivity in detecting subtle lesions. That's one of the times we do it. Cavitation, endobronchial spread, and lymphadenopathy. So when the clinician suspects TB and this radiograph is not helpful, the patient may be referred for CT scan. But if the radiograph is quite typical, the patient doesn't need a CT scan. And as I mentioned, the most common findings of active TB on the CT are similar to the radiograph, right? Cavitation, consolidation, centrilobular nodules, tree and bud pattern, and lymphadenopathy, particularly with central necrosis. When we see lymphadenopathy with central necrosis, we have to mention the possibility of tuberculosis. CT obviously has limitations, higher radiation dose, high cost, and therefore is used in a small percentage of cases. Thank you very much for your attention.
Thank you so much, Dr. Müller, for this fantastic lecture. You greatly simplify this topic. Thank you so much. Uh, we have some questions. So Patricia asked, how often do you see mediastinal adenopathy in children?
In children,
Yeah.
we see hilar lymphadenopathy, which is much more. See, most children with primary TB are children under 5. And in those cases, the thymus is very large. It's hard to see mediastinal lymphadenopathy. But we see hilar lymphadenopathy in almost 100% of children under 5 with primary TB, almost 100%. And as they grow older, when we get to adolescents, we only see it in about 60% of patients. And in young adults, as I mentioned, about 40%. But in children under 5, especially 100% have lymphadenopathy. So it's really a good marker for primary TB in very young children. It's easy to see and quite helpful in the diagnosis of TB. But mediastinal lymphadenopathy, as I mentioned, it's very hard to diagnose because of the thymus in those young children.
Thank you. Dr. Patricia is from Mexico, and she is sending you her thanks for these great lectures. Also, we have a question from Kennedy, and she asked, what is the prevalence rate of COVID-19 in TB patients?
Well, I don't think that it makes, I don't know. We don't know the answer to that question. I haven't read anything about that, but I don't think it makes a big difference, TB and COVID. Of course, I've seen patients who had TB and COVID. Patients who had diagnosed TB were being treated with TB and then developed COVID. Now, unfortunately, we had previous findings of TB, so we were not confused by the diagnosis. But if you think about it, if you have a patient that develops COVID and we don't know that the patient has had previous TB, it might lead to a confusing findings, particularly on the radiograph. On the CT scan, the manifestations of COVID are often quite typical, right? If we see these peripheral predominant ground glass opacities, lower lobe predominance, often with a slight nodular component, but they're ground glass, we think of COVID now because of the high prevalence, particularly in the US and Canada. And if we see other centrilobular nodules, that is not COVID. That is due to another infection, which could be TB. So we can on the CT suggest 2 different diagnoses, right? But I don't think the prevalence of TB and COVID are related.
Thank you. Also, Kasun Kumara asked, can we differentiate active TB versus inactive disease by assessing the thickness of the TB cavities?
Not terribly reliable. Okay. Now, if we see a cavity that is multimarginated 1 cm, that's probably residual of previous TB. But you can't be 100% sure, right? So if I see any cavity in the upper lobe, superior segment of lower lobe, I think they need to rule out active TB. Now, we also know that when we follow patients who are being treated with TB, they have these large cavities that are illustrated. They are treated. They are now cured from the TB. A number of them have residual, very thin wall cavities. But in that context, we have previous radiographs and stability of that thin wall cavity. And again, if the stability is at least 6 months, that is almost certainly inactive TB. But if the cavity is more than 2 millimeters, I would be very unhappy to call that inactive TB.
Thank you. Dr. Hasnan Nouh asks, thank you for the presentation. Can we have viral pneumonia superimposed on top of primary TB? And how can we tell?
Viral pneumonia superimposed on active TB. That can be tricky. It depends. The viral pneumonias and viral pneumonia. Try it. Coronavirus, I think, is easy. Influenza virus, I think, is easy. But there are a number of viruses, and even influenza in some cases, that may present with many nodules, central lobular nodules, in which case that might be very difficult to distinguish from endobronchial spread of TB. So although in the majority of cases, I think the differential diagnosis is relatively easy, in some cases, it may be difficult or even impossible.
Suet said, thank you very much for the informative lecture. I would like to ask if we can tell the difference between NTM and TB in imaging finding. Thank you in advance.
In some cases, it depends. In some cases, no. Actually, in many cases, no. In non-tuberculous mycobacterial may have findings identical to tuberculosis. We cannot distinguish them reliably on the CT scan. In some cases, non-tuberculous mycobacteria present in patients who have bronchiectasis, typically middle lobe and lingular involvement, and they develop small nodules, central lobular nodules elsewhere. And in that context, we will favor the diagnosis of non-tuberculous mycobacteria. So in that presentation, particularly women, elderly women with underlying bronchiectasis, with that sequence of findings in areas of low prevalence of TB, like Canada and the US, we will favor non-tuberculous mycobacteria because that's what they tend to develop. But in other circumstances, non-tuberculous mycobacteria will look identical to tuberculosis, and it will take cultures to really distinguish these types of mycobacterial infection.
Okay. And following up on America and Canada, Trinam asks, thank you so much. Which one is more common in North America, primary or post-primary TB?
What we see most commonly is post-primary TB.
Another question, is cicatricial atelectasis already a sign of inactive disease?
Sorry, what atelectasis?
Cicatricial atelectasis.
I don't know. Sorry, I don't know what you mean.
I think he meant like the fibrosis, the atelectasis that results from the fibrosis.
Oh, the scarring. Yeah. Cicatricial atelectasis. Okay, sorry. Yeah. That is a finding of inactive TB. Yes.
Can you also ask another question? Yeah, this is of the primary TB. Okay, our last question. Could you give us a hint about the differential diagnosis of TB?
differential diagnosis of TB, of the findings that we see, namely cavity, consolidation.
I think he meant to, he didn't mention, but I think the cavity is the most specific one, right?
Okay, when you see a cavity, it depends on the location, right? A cavity can be due to a number of causes. It can be cavitating from any other infection. In certain regions of North America, histoplasmosis is a common cause of cavitary disease. Also, it's very common in countries like Mexico and in the areas of South America, histoplasmosis, in which case it can look identical to tuberculosis. Any infection, any bacterial infection, bacterial abscess can cause cavity. Cancer, particularly squamous cell carcinoma, and even adenocarcinoma can cause cavitation. Metastasis can cause cavitation. It's a broad differential diagnosis. However, when you see the cavity in the apical or posterior segment of an upper lobe or the superior segment of the lower lobe, in that broad differential diagnosis, we have to also consider TB.
Okay. We have a suggestion from Tenzin. He said, "Thank you so much for the excellent lecture. It will be a great pleasure and honor to hear you talk on pediatric TB radiological findings next time."
Thank you very much.
Thank you very much, Dr. Müller. It was a pleasure and honor to moderate your lecture, and it was very informative. Thank you so much.
Thank you. Bye.